mahaba-haba yung usapan natin today. This is chapter 21, muscle blood flow during exercise. And the next part is about coronary circulation. And then lastly, we will talk about ischemic heart disease. So, exercise muna. What really happens? At rest, the muscles of our extremities receives blood about 3 to 4 milligrams per minute per 100 grams. But during exercise, it increases to up to 100 to 200 ml. So sobrang laki ng pag-increase ng blood flow. So the peak blood flow can rise to 400 ml. So this is a good mechanism na at rest, konti lang, and then during exercise, there is an ability of our capillaries to increase its blood flow towards the muscle.
Doc, choppy.
Nasa bahay lang kasi ako ngayon because parang I woke up late. And so I wasn't able to go to the hospital. But anyway, let us hope and pray that the signal will help me. So if you look at the x-axis in minutes, and at 10 minutes to 60 minutes, the patient exercised, and look at the effects of blood flow. Sobrang taas ng blood flow during muscle contraction. Yun lang yung ibig sabihin. And at rest, some muscle capillaries have little or no blood flow, but during extreme exercise, all the capillaries will open. So there are mechanisms to dilate the arterial, but the most important is reduction of oxygen. When you start working when you start exercising, the muscles consumes oxygen in the capillaries, and this would reduce oxygen. And we have discussed this about local transfusion, local blood flow, that a reduction of oxygen is the most powerful, most important way to vasodilate the arterioles. So it would, active muscles will decrease oxygen in the tissue fluid and will cause or substances that vasodilate. Nervous control and increase the flow to the heart rate through the sympathetic vasoconstrictor nerves. No, don't confuse about vasoconstrictor nerves, because sympathetic activity will vasoconstrict all the arterioles to other muscles or smooth muscles or organs that need blood supply. And there are 3 exemptions, one going to the brain, to the heart, to the muscles of the heart, and as well as skeletal muscles. So hindi mo pwedeng palitan yung sympathetic vasoconstrictor nerves. And that's because the receptors used, or the receptors that are present in the skeletal muscles, are of beta adrenergic receptors, which cause vasodilation rather than vasoconstriction. So sympathetic nerves, vasoconstrictor nerve endings have this norepinephrine that would cause a decreased blood flow to resting muscles. It would decrease blood flow to gastrointestinal tract, for example. And this is important in circulatory shock because you want to deviate blood supply to important organs like the heart. But again, on exercise, it would include skeletal muscles. But during circulatory shock, it will not include the skeletal muscles. So the adrenal glands as well produces norepinephrine and epinephrine, and this is different from norepinephrine in the sympathetic. Norepinephrine will be released via the bloodstream and go to wherever in the body. Again, the net effect will be the same with that of the sympathetic nerve. Epinephrine has some slight vasodilator effect because epinephrine excites more of beta adrenergic. So there are confusing effects between epinephrine and may nagchat, di ko mababasa. Wait lang. Sorry. Choppy pa rin hanggang ngayon?
Di na masyado.
Okay, you have to interrupt me one while. So, narinig so far lahat ng sinasabi ko?
Hindi, Doc.
Hindi. Hanggang saan lang? How about dito? Narinig niyo to?
Diyan, Doc, medyo nag-start na hindi na talaga clear.
Okay. So, there are vasodilator substances, but the most important is reduced in oxygen. So, there are other ways to vasodilate the vessels in the muscles, and that's through sympathetic activity. When you start exercising kasi, there will be increase in sympathetic activity and decrease in parasympathetic activity. And it would, of course, increase heart rate, contractility of the myocardium, and it will vasoconstrict most of the vessels going to, let's say, gastrointestinal tract. But on the muscles, it will cause vasodilatation. So don't be confused about that. At the nerve endings, kasi there are norepinephrine, and this norepinephrine will have an effect depending on the receptor that it stimulates. And so in the extremities, the receptors there are beta adrenergic. The net effect is vasodilatation. But on other vessels, let's say the gastrointestinal tract vessels, ano nandoon alpha. So the net effect will be vasoconstriction. All right. So the adrenal gland as well produce epinephrine and norepinephrine. This is different from the epinephrine that is in the nerve ending, because yung epinephrine at saka norepinephrine that is released from adrenal glands will be released into the circulating blood and will go to different receptors, although the net effect will be somehow the same depending on the receptor that it will stimulate. But epinephrine has a little bit more of vasodilatation because some of its effect will be directed towards beta-adrenergic as opposed to alpha, which is more of vasoconstriction. So don't be confused. There are beta receptors that can vasoconstrict and vasodilate. There are also receptors like alpha receptors that can vasodilate and vasoconstrict depending on an organ. So we will discuss that once we go to. Okay ba?
Yeah, we heard it, Doc, pero medyo nagiging choppy na again yung signal.
Strider siya, no? Bakit pag na-Netflix ako, bongga? Pero pag nagle-lecture, chararat. Okay. So when you do exercise, these are the three major effects. One is a mass discharge of sympathetic activity. And of course, there will be an inhibitory effect with parasympathetic. Another effect is an increase in arterial pressure. And another effect is an increase in cardiac output. So think of how sympathetic activities can do all these activities. So sympathetic discharge, of course, will increase heart rate. Alam na natin yun, it stimulates the SE node to increase its firing rate. And at the same time, it will also increase the pumping strength of the, that's what we call as inotropic effect. Kasi alam niyo kung mabilis lang yung heart rate without increased contractility, hindi rin masyado tataas yung cardiac output. This happens in patients with MI or patients with and so these two of stimulating increase in heart rate and increase in contractility increase the cardiac output. And arterial, the peripheral circulation strongly contract, meaning choppy na. Wait, it's only okay na. Yeah, so biochemo, tsaka nagbasakali ako maganda because last time naman nang we had a Zoom meeting, okay naman dito sa bahay. Siguro meron lang moment. Ayan, naririnig niyo na ako?
Yes.
Okay. Activity will, alam na natin yan, will increase the heart rate and increase the contractility. And this two-way mechanism is important to increase the heart rate. I mean the cardiac output. Kasi pwedeng increase lang yung heart rate pero hindi improve yung contractility. The cardiac output will not be much increased. Narinig nyo yun?
Yes.
For example, sa heart attack patients, kahit there is increased sympathetic activity, ang taas ng functions ng heart rate, meaning ang bilis ng heart rate. But the cardiac output does not increase much because of a decrease in contractility. This is one example na dapat dalawa. If you want to increase the cardiac output, you have to increase both the heart rate and the contractility. So another effect of sympathetic nerves is it causes vasoconstriction to almost all organs except arterioles to the muscles and arterioles to the heart and the brain. So when you are exercising, you need more blood supply to the muscles of the extremities. And di ba maganda yon? Because you can, with this ability, you can exercise. Especially kung may emergency, you can run immediately. So imagine nyo kung pati yung vessels sa skeletal muscles vasoconstricted, edi para kang paralyzed. Narinig nyo yon?
Yes, Doc.
Yes po, Doc.
Nakakaloka yung pag-send. Pagong din. So, the muscle walls of the veins, this is another mechanism that increases the cardiac output. Kasi yung nagvasoconstrict din yung veins. Alam natin, the veins has a lot of capacity and it contains a lot of blood volume. So if these veins will vasoconstrict, meaning magdi-decrease your internet connection is unstable. Naririnig niyo ako? Can you hear me?
Good, Doc.
Yes, Doc.
So if the veins will vasoconstrict, it will drain blood into the right atrium, increasing the venous return. And this is one way to somehow increase the cardiac output. So an increase in cardiac output is complemented with an increase in venous return. Last time kasi may mga students nagtatanong, di ba Doc, increase in total peripheral resistance will also increase the blood pressure. That is right, but this is opposite sana. Dapat cardiac output will decrease. That is actually right based on the formula, but somehow during exercise it deviates a little bit because the cardiac output will increase as well. And I'm trying to explain to you the mechanisms bakit hindi siya nagpa-follow sa formula. Nagigets nyo? That's the explanation there is, one, there is an increase in contractility of the myocardium, which squeezes the blood out, increasing the stroke volume. The second is there is also vasoconstriction of the veins, which drains or increases the venous return. So complementing the increase in cardiac output, there is also an increase in venous return. Both of these will maintain an increase in cardiac output. Without these mechanisms, the cardiac output will decline because you have vasoconstricted arterioles, decreasing blood flow to capillaries. Kaya yung blood sana napupunta sa venules and then go to the large veins and then the right atrium will somehow be decreased. So eventually the cardiac output will decrease. But because of these mechanisms, the venous return is increased to complement with the increase in cardiac output. And these mechanisms maintains an increase in cardiac output. Did you hear that? Hello?
Yes po, Doc. Pinadigest.
Dinadigest pa. Okay. Kasi di ba, yung sa formula ng Ohm's law, if you increase the total peripheral resistance, kasi di ba, increase in sympathetic activity vasoconstricts the vessels, the total peripheral resistance will increase and the blood pressure will increase because of this. Tama? Kasi a smaller lumen decreases the area, and this would increase the pressure. And supposed to be the cardiac output will decrease, but there are mechanisms to increase the cardiac output. And kaya hindi siya nagpa-follow sa Ohm's law during exercise. I mean, because one, there is increase in contractility of the myocardium, and second, there is vasoconstriction of the veins, so it will cause an increase in venous return. Nangangalahati pa lang yung slides. Sorry. So, ganun na siya. The blood pressure, di ba, sabi ko sa inyo, there are three ways, the three major effects of exercise. One is increase in sympathetic activity. The second effect is an increase in arterial pressure, increase in BP. And siguro kahit as of now, as students, makakapag-isip na kayo, paano tumataas yung BP during exercise? So one explanation is because of vasoconstriction of most of arterioles and small arteries, supplying the inactive muscles. But of course, except the active muscles, hindi yun nagvasoconstrict, nagvasodilate yun. And the second reason bakit tumataas yung BP is an increase in pumping activity of the heart. It increases the stroke volume. It will increase the blood pressure. And the third effect is an increase in mean systemic filling pressure. Again, because the veins can vasoconstrict as well, increasing venous return, and venous return will increase the filling pressure. Meaning the diastolic filling pressure is increased somehow, and so it will improve a little bit the blood pressure, but not too much, not too much. So, increase in arterial pressure during exercise can increase as much as 20 millimeters mercury to even 80 millimeters mercury. Additional, additional. Kunwari, ano siya, 100, grabe no, 100 plus 20, di naging 120. Pwede ding 80. So 100 plus 80, so 180 millimeters mercury ng BP niya. Kaya expected yon mataas yung BP during exercise. As a cardiologist, nag-treadmill din kasi ako sa patients at nakikita kong tumataas talaga yung BP during exercise. But we have indication to say if the increase in BP is abnormal or if it's physiologic. Because if the increase is 20 millimeters mercury every 3 minutes, normal pa yon. Pero kunwari, less than 30 minutes, yung increase is 40 millimeters mercury. Hypertensive na yung reaction. Nakuha niyo yun? Narinig niyo yun?
Yes, Doc.
It's okay. Yehey. Mag-share kaya ako habang nagsisend siya.
Maybe you can try, Doc.
Okay. Ayan, nakikita niyo. Okay. The cardiac output is important during exercise. Kasi paano naman mag-i-improve yung blood supply to the muscles if the cardiac output will increase? And that's also the reason why you want to vasoconstrict the vessels to other non-active muscles. Because you want to deviate the blood flow to muscles, to the brain, to the heart. Di ba alam na natin yun na yung cardiac output naman, hindi ka naman nagpo-produce ng new red blood cells in a matter of few seconds. And so if you want to increase the cardiac output, yung 5 liters na yon in the blood, in the circulating blood, kailangan mo lang siyang i-deviate kung saan mas may nangangailangan. Ganun lang siya. Okay. So, I hope na intindihan niyo yung mga graph na to. There is that venous return graph, yung pababa, and there is that, di ko makita yung arrow eh. And then there's that cardiac output yung pataas. So normally yung sa block, you have that equilibrium point at 0 RA pressure. But during exercise, tingnan nyo, tumataas siya. Yung RA pressure niya is about 3 millimeters mercury. But the cardiac output and the venous return both increases. So ito yung in-explain ko kanina. There is a match, parang yung increasing cardiac output is matched with an increase in venous return. Di ba dapat whatever is the cardiac output, that should equal the venous return. Yun yung normal physiology, dapat parehas sila. Kung 5 liters yung cardiac output, 5 liters din yung venous return. Dapat na ibabalik niya. If there is a mismatch, yun magiging problem yun. For example, the venous return is 5 liters, pero the cardiac output is only 3 liters. So somehow the 2 liters is in the lungs. It will cause congestion. Or, for example, the cardiac output is 6 liters, the venous return is only 3 liters. So along the way, from the arteries to the veins, there is an obstruction. Magiging problem din yan. So you want to, the purpose of the heart is to maintain that venous output always at the same time. So if you want to increase the cardiac output, the venous return has also to be increased. Otherwise, if the venous return will not follow, then you cannot maintain an increase in cardiac output. Nakuha niyo yun? Did you hear that?
Yes, Doc.
Okay. So, the increased level of cardiac output curve results from sympathetic stimulation. It will increase the heart rate. It will increase the contractility of the heart twice as normal. Okay. Paulit-ulit lang siya. It increases the systemic filling pressure. And during maximal exercise, the mean systemic filling pressure increases from 7 to as high as 30 millimeters mercury. And the slope of the venous return also increases as both the cardiac output and the venous return increase. So, kung tayo sa muscle exercise, lang naman yung your internet connection is unstable. You can hear me pa rin?
Yes, Doc. Medyo choppy lang.
Oo, parang fluctuating lang siya every 5 minutes. Mawawala yung signal. Discord. So, lang. You just point out most important. Nakakaloka. Andyan pa ba kayo?
Yes, Doc.
Yes,
Yes,
Doc.
Doc.
Wala. Dapat pala magdadasal tayo, no? Ano kaya yung pag-send ko? Ay, nawala din.
Pasa na lang, Doc, sa email.
Ha?
Email, Doc.
Resend? Email? Mas mabilis ba yun? Okay. Kanino ako mag-i-email? What's your email address? Rueda.
I will chat po sa'yo. Sandali lang po.
Ayaw niyang i-agay dyan. Baka may mag-email sa'yo. Saan ka mag-text sa chat box ng Zoom?
I can sa Facebook po pwede naman i-chat ka.
Sige, sa Messenger.
Doon kasi before.
Aside kay may kamay, whoever messages me. So, during exercise,
Messenger, kada ako na 5.
So sa exercise, kailangan nyo lang malaman na vasodilation sa skeletal muscles, constriction to the other capillaries, arterioles and capillaries. And there are mechanisms to do this. One is because of the decrease in oxygenation, the arterial layer will vasodilate, and the most important, of course, is yung ng sympathetic activity that increases the heart rate, increases the contractility, and increases the venous return. Ay, wait lang. Joanne with double N.
Yes po, Joanne Christie.
Christy. Christy. Failure. Failure talaga ang signal. I was hoping na ano na siya, okay na siya. Siguro pag ano, nag-zoom kasi ako sa gabi, okay naman yung signal. Pag sa morning, pangit.
120 kasi kami.
Ha? Pag 120, affect yun.
Kasi mag-consume rin yan ng data.
Talaga? Hindi ako na-inform. Ganun pala yun. Loading pa rin yung sa sa Yahoo. Hala, baka malaking file, girl. Feeling ko malaking file, hindi siya masisend. Anyway.
Sa email na lang po ata.
Kaya nga, I am trying to anyway, naglo-load pa siya.
Okay po.
It's loading. Let's try pag mag-email din kaya ako dito sa Zoom, ganun din yung effect. Let's try again. Bahala na si Batman. Kaya natin yan. Wala lang. Ang toxic ko pa naman today. Daming admission. Okay. And for some reason, I was about to wake up at 5:30 para mag-start ng mga rounds. Nagising ako 7 o'clock. So good luck. Kita niyo yung slides. I hope kikita niyo. There are 2 coronary sinus, meaning opening at the aorta. And on the right, coronary sinus, and that's the opening to the right coronary artery. And then on the left is the left coronary sinus will open to the left main coronary. Tapos, eventually, this left main coronary will divide into left circumflex artery and left anterior descending artery. Wait lang, nakakaabala yung chat. Okay. You don't need to memorize that. I'm just trying to show you that there are 3 major coronary arteries: the right coronary artery, the left circumflex, and the left anterior descending artery. Depending on the location, these arteries will supply the myocardium. Let's say the left coronary artery will supply almost all of the anterior and the left lateral portion of the left ventricle, while the right coronary artery will supply the right ventricle and some of the posterior part of the left ventricle. The coronary sinus, this is different. Don't be confused about the coronary sinus in the aorta, because we also name it as coronary sinus, that opening towards the right coronary artery and left coronary artery. Coronary sinus. There is another coronary sinus, which is a vein. This is a collection of all the veins in the myocardium. Ang tawag niyan is coronary sinus, then that's a vein. It will drain into the right atrium. So anterior cardiac vein is another vein that will drain from the right ventricle through the right atrium. Sebacean veins also directly empty into the chambers of the heart. But almost all of the veins will be collected by the coronary sinus and it will drain to the right atrium. So there are three vessels that drain into the right atrium. One is the superior vena cava, second is the inferior vena cava, and the last is coronary sinus. Okay? Nakuha niyo yun?
Yes, Doc.
Hello?
Yes po, Doc.
All right. So resting coronary blood flow is about 70, but during exercise, it will increase fourfold. And alam na natin yon na the brain, the heart, and the skeletal muscles will all have mechanisms to increase its blood flow. Okay? And efficiency of cardiac utilization of energy increases to make up for relative deficiency of coronary blood flow. Yun lang. So, this is important because minsan lumalabas siya sa board exam and this is basic physiology. So if you look at the image, the figure, the coronary blood flow and then the x-axis is either or diastole. If you look at during systole, there's a decrease in coronary blood flow, and during diastole, there is an increase in coronary blood flow. Narinig niyo yun?
Hindi, Doc.
Doc, from the top.
Hindi. From the top. So, if you look at the figure, the y-axis shows you the coronary blood flow and the x-axis shows you the phase of the cardiac cycle, either systole or diastole. So there is a decrease in blood flow during systole and an increase in blood flow during diastole. So most of coronary perfusion is during diastole and not during systole. Bakit? Because the coronary artery has the blood flow in the coronary artery diffuse from high pressure to low pressure, meaning the coronary artery must have a higher pressure as compared to the myocardium, where the capillaries are there. Naintindihan niyo yun?
Yes, Doc.
Hello? Okay. So if the myocardium contracts during systole, what will happen to the pressure? It will increase because as the myocardium is contracting, the capillaries there will be compressed. So the capillaries and the arterioles are increased somehow. So the coronary arteries cannot drain. Nakuha niyo ba yun? Did you understand?
Doc.
And that is the reason why coronary perfusion is mostly during diastole and not during systole. Okay?
Okay, Doc.
All right. Yay. So, the origin of coronary artery will start from the epicardium and it will penetrate to the center of the myocardium and then into the endocardium. But the blood flow will start from the epicardium. Kaya during contraction, it is the subendocardium which will be more affected. Kasi siya yung mas malapit sa chamber, sa loob ng chamber. Nandoon yung mas malakas yung contraction ng myocardium. So these vessels, subendocardial arterial plexuses will be compressed. So there will be no blood flow. Whereas the epicardial coronary arteries, somehow, kahit mataas yung pressure, somehow will be able to deliver of blood during systole. But during diastole, all of these vessels will have a blood supply. The beauty of coronary blood supply is, when I was studying it, I was really surprised how beautiful yung mechanism niya to supply the myocardium. Kasi ganito nangyayari. During systole, the subendocardial arterial plexus are compressed, so there will be no blood supply. And because of that, there will be decrease in oxygenation. Whereas the epicardial coronary arteries will have a little bit of blood supply. During diastole, di ba decrease na yung blood supply, walang decrease yung oxygenation to that area, to that capillaries, and to the myocardial tissue. During diastole, it will vasodilate maximally to compensate. Kaya during diastole, mas maraming marireceive ng blood yung subendocardium. Kasi dilated siya. Naintindihan niyo yon? Hello?
Yes, Doc.
So, during diastole, the subendocardial layer will receive more blood supply as compared to the epicardium. And this is because of vasodilation at the subendocardial arterial plexus. Because during systole, they are compressed. It will not be able to receive blood supply. And so there will be decreased oxygenation. At alam na natin, a decrease in oxygenation is a very powerful way to vasodilate the arterioles and the capillaries. And so during diastole, the subendocardial arterial will vasodilate maximally, and it will deliver blood to the myocardium twice as much as during diastole. Yung maganda din naman sa epicardial layer is that it receives blood supply even during systole and diastole. Okay? I hope naintindihan niyo yun because this is epicardial versus subendocardial. And this is important because in myocardial infarction, there are two types of myocardial infarction. One is what we call a subendocardial ischemia, meaning to say, yung epicardium, hindi walang ischemia, yung outer layer walang ischemia, but the inner layer has ischemia. The subendocardial layer lang yung nagkakaroon ng ischemia. At this is because of the physiology that the subendocardial layer receives less blood supply. For example, if the coronary artery that di ba nag-i-start siya sa epicardium is a little bit is obstructed by 60%, 40% na lang yung nag-flow, that 40% will be delivered mostly to the epicardial layer. Kaya kawawa si subendocardial layer. Kasi mahuhuli siya eh. 40% na lang kasi yung ang blood flow. So most of the blood supply, if there's a scarcity of blood, most of the blood supply will go to the epicardium and the subendocardial layer will have ischemia. Did you hear me?
Yes, Doc.
Hello? That's
heard.
important. That's the mechanism. Yes. That's the mechanism behind subendocardial ischemia, which is the pathophysiology of non-est elevation, myocardial infarction, and unstable angina. Whereas in est elevation MI, the pathophysiology is 100% obstruction of the coronary artery. And so all the layer, the epicardium and the subendocardial layer will be infarcted. Kaya ang tawag niyan is transmural myocardial infarction. Lahat ng layer is infarcted. That's the pathophysiology of est elevation MI, transmural MI. Whereas in non-est elevation MI and unstable angina, ang nangyayari sa kanila is only the subendocardial layer is infarcted. Did you understand? Hello? Narinig niyo yon?
Yes, Doc.
Okay. Matagal-tagal pa to. That's related mostly by arterial vasodilation. Whenever there is an increase in cardiac contraction, then the blood flow has to increase. Whereas a decrease in heart activity will decrease the coronary blood flow. So, how does the oxygen demand is a major factor for local coronary blood? Alam na natin yan. Whenever you do exercise, the myocardium increases its contractility, and so the oxygen will be used up, and so there will be hypoxemia in the myocardium, and this hypoxemia is a powerful mechanism to cause local vasodilation. Okay. Now, aside from that, there are also nervous control, which is increases in sympathetic activity, inhibiting the parasympathetic activity. So this norepinephrine and epinephrine will cause the vessels to vasodilate. Indirect effect, which are mostly opposite to direct effect. So kung opposite naman, if you relax, then more parasympathetic and less sympathetic activity. I don't need to explain that siguro naman na. So, acetylcholine is more of parasympathetic, whereas sympathetic is more of norepinephrine. But again, there is that epinephrine that is released from the adrenal glands. And so depending on the receptor, it will cause either vasoconstriction or vasodilation. So in the heart, beta receptors causes dilatation, while alpha receptors causes constriction. Yay! Gusto mo ikaw na mag-share?
Sige, Doc.
Sige nga, dahil I'm excited. Parang social lang, no? Pag kasi ako, nag-attend ako ng mga Zoom meetings. Tapos yung professor nagsasabing, next slide. Oh, I kind of like it. I want to say next slide.
Wait, Doc, yung gamit mo ay Apple?
Yes. Hindi mo ma-open.
Sa laptop, kailangan ko i-open yung iPad ko. Sige, continue muna. Magko-connect lang ako.
Okay. You just tell me whenever okay na. Where is that? Diyos ko Lord, bukas pa tayo matatapos sa lecture, no? Okay. Dami slides pa naman, no? So, under resting condition, cardiac muscle normally consumes fatty. In-explain ko na to fatty acid synthesis, but sometimes we use this glycolysis, but only during MI. Ang mahirap lang, we were born to use fatty acid synthesis. And so, if there is myocardial infarction, okay sanang gumamit pa ng glycolysis. But you cannot change your genes in a matter of days, diba? And that's why you need medicines to somehow convert a little bit of glycolysis to produce. So meron naman tayong mga medicines to do that. Kaya, tiwala lang. Ayoko na to. So you need ATP in order to function. You need to produce more ATP if you are exercising well. Okay. Skip na lang. The most common cause of death is ischemic heart disease. And ito yung gist ng practice ng cardiologist, yung ischemic heart disease. Pag sinabi natin ischemic heart disease is, parang napakalaking umbrella niya kasi hindi naman lahat ng ischemic heart disease is caused by coronary artery obstruction. Let's say if there is severe anemia, 40 na lang yung hemoglobin, kahit naman walang bara yung artery, magkakaroon ka rin ng ischemia, myocardial ischemia because of decreased delivery of oxygen. Let's say the patient carbon monoxide toxicity, di ba? It will carbon monoxide has more affinity to hemoglobin, and so ganun din yung effect niya. That's ischemic heart disease. So that transient ischemia can be permanent, and so it can cause ischemic heart disease. So I'm just trying to explain to you that ischemic heart disease is a big umbrella, and not all ischemic heart disease is caused by coronary artery obstruction. But coronary artery disease is a major cause of ischemic heart disease. And the most common cause of coronary artery disease is, of course, atherosclerosis. When we say atherosclerosis, there is building of plaque formation, and this plaque formation will occlude the lumen, decreasing the blood flow. And this is genetically predisposed, some obese or overweight, and sedentary lifestyle, and of course, high blood pressure. Because if you have a high blood pressure, it damages the endothelium, and any damage to the endothelium is a precursor of atheroma formation. Maintindihan nyo yan once you go into internal medicine. Okay, so gradually these areas of deposit are invaded by fibrous tissue, and then it will be calcified, and then that's the atheromatous plaque. So this atheromatous plaque can increase in its size, decreasing the lumen and obstructing the blood flow. Amazing lang sa myocardium, kahit yung bara 50%, halos wala pa yung effect. It will not cause ischemia. Obstruction is 50%, meaning 50% na lang yung dinadaanan ng dugo doon sa lumen ng coronary artery. Because if there is obstruction, the coronary arteries will vasodilate and it will somehow increase the blood flow. But if the obstruction is now 70%, 60 to 70%, then there will be manifestations of ischemia already. Okay? So if there is coronary artery occlusion, it results from several factors. One is atheromatosis, and this plaque can either be removed or dislodged, and it will obstruct downstream to smaller arterioles, and it will cause ischemia or infarction. This is what we call as an emboli. So another mechanism is kahit wala namang plaque formation, walang atheroma formation, walang obstruction sa coronary artery, but if there's what we call as coronary spasm, meaning the artery, the smooth muscles nag-contract, alam mo yun. So it will cause vasoconstriction and it will decrease blood supply. And if this coronary spasm will last more than 5 minutes, it's collateral vessels are important because if you have collateral vessels, it will decrease the infarcted size. It will somehow keep the patient alive, yung collateral vessels. So there are people now born to have a lot of collateral vessels. So diabetic patients, it destroys collateral vessels. Sobrang liliit ng arterioles nila to the point na wala ng collateral vessels. So if you look at this image, ano sila, di ba? Merong connections. Yan yung collateral vessels. Say for example, this one is obstructed. So this artery can somehow supply this area. So that's the beauty, if there is connection. Naintindihan nyo yun? Hello? Hello?
Yes, Doc.
Okay. There are other collateral vessels na parang, kunwari, this artery, meron din dyan artery na nagsusupply to that area, artery, na hindi lang siya, collapse lang siya, but you were born to have that artery there, pero collapse lang siya, meaning hindi pa siya nagpa-function. And then eventually, during myocardial infarction, if this artery will be obstructed, the collateral vessel will dilate, it will be opened up, and will be able to supply that area. Meron yan, kaya magdasal ka na marami kang collateral vessels. There are people who are born with a lot of collateral vessels, meaning andun lang siya, natutulog lang yung collateral vessels niya. Okay, pwede na daw siya mag-share, dali. So yung collateral vessels is one explanation bakit yung ibang patients, pag nag-AMI sila, hindi malaki. And then there are people without collateral vessels, if they have myocardial infarction, the infarcted size is big. So collateral vessel is a major factor for you to have a decrease in myocardial infarction. Parang slide number 30-something na tayo.
Wait lang, Doc. What number na po, Doc? Slide?
Sige lang, nandun na sa collateral vessels tayo. Prototype example of a patient, next pa, is those patients na diabetic patients, yan. Next. Diabetic patients, they don't have much collateral vessels, kaya pag diabetic patient, talagang malaki yung infarcted vessel. Sige yan, life-saving, yan. So yung collateral vessels, minsan, yung sinasabi ko, hindi lang connection. Minsan talagang merong additional arteries na collapse lang, supplying to that area. For example, merong kang area dito, merong isa pang artery na nandun lang, collapse lang siya, but it is about going to supply this area. Pero collapse lang siya, so hindi pa siya nagsusupply. And then, if this artery is obstructed, that collateral vessel will open up, but it will take the next 8 to 24 hours for that collateral vessel to increase its diameter. Next.
Wait, Doc, nawala.
Nawala yung? So after how many days that collateral vessel can vasodilate maximally, and it can improve circulation. And this is the reason why even after myocardial infarction, if you have a collateral vessel, some patients recover faster. And some patients after 2D echo, wala nang hypokinesia. Alam mo yun, wala silang residual hypokinesia. Yun yung explanation if they have collateral vessels. So dapat magdasal ka na meron kang collateral vessels. Otherwise, if you don't have collateral vessels, wala ka ng other way to supply unobstructed myocardium. Okay. Nandun na tayo sa collateral vessels. Naintindihan niyo yung collateral vessels? Hello? Next slide. Ayan, yan. So, there are, these collateral vessels can still have, but the sclerotic process develops next na. Yan. The sclerotic process develops beyond the limits of even the collateral blood supply to provide the needed blood flow, and these collateral vessels can still have atherosclerosis. So, importante din na you still give medications, let's say statin and antiplatelet. Kasi kahit nabuhay na yung patient after the MI and then naka-recover siya completely because of the collateral vessels, these collateral vessels can still have atherosclerosis. At kung ma-obstruct na yon, goodbye, na wala ka ng additional way to deliver blood to that infarcted area. Okay, next slide.
Doc, sorry, always nawawala.
Yung ano?
Yung slide sa akin.
Ako na lang, don't worry. Let's try. Okay lang. So, this is the reason bakit yung iba, pag nag-EMI sila, hindi ganun kalaki. O, hindi ganun kalaki yung yung infarction. And this is the reason why some patients recover or do not have heart failure after an infarction if they have collateral vessels. Okay? So when atherosclerosis constrict the coronary arteries slowly over a period of many years, the collateral vessels will develop slowly. So magkaiba ang patients na kunwari nagkaroon ka ng embolus and then this will obstruct the arterioles and then eventually causes heart attack. So iba yon ang mechanism. The patient will have angina and will have an overt MI versus a patient na slowly lang siya. Alam yon, yung coronary artery niya is slowly building yung plaque and then increasing yung size ng plaque so that the lumen is decreased. Because if this process kasi longer yung production ng atherosclerosis. So the collateral vessels will also slowly develop and it will prevent chest pain. So there are patients na hindi nagkakaroon ng chest pain. Maraming patients na pagdating sa'yo, meron na silang old MI on ECG. Pagtingin mo sa 2D echo, meron na silang hypokinetic area. Nag-MI na pa sila without chest pain. And that's because slowly developing yung coronary artery disease, and there is also coronary collaterals. So although nag-MI sila, but not big enough as compared to other people without collateral vessels. So collateral vessels is really life-saving. Okay? Yay. So in coronary artery, ganito ang nangyayari. So there is that plaque formation, and if that plaque formation is more than 70%, I've been explaining, meaning 30% na lang, hindi dinadaluyan ng dugo, that can cause myocardial infarction. So at rest, okay lang, wala pang chest pain yung patient kasi meron pa namang 30%. But during activity, the myocardium has to contract and the myocardium needs more blood supply And then what will happen is there will be mismatch. There will be demand, decrease in supply, and it will cause ischemia or infarction. Kaya most of angina or chest pain occurs during activity. Did you understand? Narinig nyo yon? Hello?
Yes, Doc.
All right. So, cardiac muscle requires 1.3 ml of oxygen per 100 grams of muscle tissue per minute just to remain alive. And if there is obstruction, once this is not delivered, then it will cause an MI. At rest kasi kahit barado yung coronary artery, since nagbabasodilate yung coronary artery, somehow this 1.3 ml required oxygen will still be delivered. But during activity, because of an increase in demand, then ayun na, nakakakos na ng MI. Kawawa is the subendocardial layer, and I have been explaining this because if there is obstruction of the coronary artery, let's say 30% na lang yung dumadaloy na dugo, this 30% of blood will be delivered mostly to the epicardial layer. And then the subendocardium will have blood supply. Kasi maximally dilated na siya even at rest. Diba, pag constricted siya during systole, and then during diastole, maximally dilated na siya. Nagigets niyo ba yon? So during an infarction, if there is coronary artery obstruction, the blood supply is now 30%. The epicardial arteries will vasodilate. Oh my God. Nag-vasodilate the epicardial artery in response to the 30% na lang na blood supply. So it will receive that 30% of blood and deliver to its capillaries. Samantalang si subendocardial arteries, dilated na siya all the time. Wala na siyang maidadilate. Kaya kawawa siya. It will not receive blood supply. And that's why there are patients na ang MI nila is the subendocardial layer, not the epicardial layer. So if you look from outside, okay yung muscle. But if you look from inside, there is infarction. That's the pathophysiology behind non-ischemic angina. Okay? Did you understand that? Hello? Hello?
Yes, Doc.
Yes, Doc.
Ay, maliwanag na ang maka-transfer nga dito sa likod. Okay. Yan. Okay. Ganyan na lang. So the most common cause of death from an MI is either from a decreased cardiac output, hindi ko na kailangan explain yan, of there's pulmonary edema. Some patients are intubated, and then pag na-intubate sila, too late na. Eventually, they will have decreased oxygenation and the patient will die. Some patients with lung infarction can have fibrillation. Alam na natin, pag defibrillate, the patient will die immediately pag hindi sila ma-defibrillate. And some of the patients can have rupture of the heart. In my cardiology training, meron akong 2 patients na nag-rupture yung heart. Ang ibig sabihin ng rupture, kasi pag nag-MI yan, yung myocardium is soft na parang pwede siyang mabutas. I mean, we call it ventricular septal defect na from an MI, not from a congenital anomaly. And that rupture, yung bleeding the blood will go either to the right ventricle or it will go outside into the pericardium and cause tamponade. Kaya namamatay sila. So sa Philippines, parang sa report, meron lang isang nabuhay na ganyan. Most of them, they will really die. Kaya catastrophic din yung MI. Yung nakikita nyo itong nagbo-bulge na to, can you see this? Aneurysmal ang term namin yan. So if for example nag-infarct magkukontract itong normal na muscle. Pero ito, dahil hindi siya nagkukontract, palabas yung nagbo-bulge out siya. That's difficult kasi there will be some blood retained there. And then hindi siya nakakatulong sa contraction, nakakaano lang siya, abala lang siya. So imbis na yung blood na sa area na yan will be delivered outside, nababawasan yung cardiac output, and that's bad. Okay, that's bad. And yan yung another way, another mechanism bakit namamatay yung ibang patient. Because it can cause cardiac shock. Tapos, that area can sometimes cause thrombus formation. Kasi di ba, ano yan dyan eh, there will be stasis of blood there, nandun lang yung dugo. And we know if there's a stasis of blood, it can result into thrombosis, and this thrombus can embolize and cause a stroke. Did you understand that?
Yes, Doc.
Hello? All right. So, yung coronary shock, cardiogenic shock, I will explain that tomorrow. But cardiac shock almost always occur 40% of infarction of the left ventricle. And ito yung bakit pag nag-EMI yung patient, we admit them at the hospital because they can have respiratory shock. And they must be managed immediately, either giving inotropes or giving volume of blood. Pero ingat lang tayo. I mean, not volume of blood, but hydration. We give lactated ringer solution, something like that, to somehow improve the cardiac output. But inotropes are really helpful. But 70% of this patient will just die. Kaya mataas din ang mortality, no? So daming of blood in the atrium, in the lungs, or systemic circulation, it will increase capillary pressure in the lung. It will diminish the cardiac output. It will diminish the blood supply to the kidney. And then the kidney will fail if the blood pressure is less than, if the mean arterial pressure is less than 60 millimeters mercury, alam na natin yon, it will, wala ka ng urine output. And then eventually, because wala kang urine output, there will be adding to blood volume, and there will be congestion, and then heart failure, and then eventually pulmonary edema, and then the patient will die. Ganun siya. So some way along the way, you have to do something to prevent this. Either you give nitrates, which vasodilate the veins, para alam na may capacitance kasi yung veins. So if you vasodilate the veins, you somehow decrease the venous return, you somehow decrease the pulmonary congestion, or you intubate the patient, or you diurese the patient, paihiin mo, you put a catheter, or you dialyze the patient to remove fluids in the lungs. So para mabuhay yung pasyente. So these are ways to prevent pulmonary edema and prevent death. Pasyente, mahirap lang kasi walang, ano yun eh, walang stroke volume. So kailangan na CPR yung patient. Manual pumping of the heart will somehow give a stroke volume, or you have to defibrillate the patient. Otherwise, the patient will die. Okay? So during first minutes after infarction, or 1 hour after a short period of, there are two especially dangerous coronary infarction during which fibrillation occurs. One is 10 minutes after infarction, or 1 hour after a short period of relative safety. For example, na-admit mo na yung patient, nagbigay ka na ng streptokinase, okay? Nagbigay ka ng streptokinase, and then na-open mo yung infarcted, yung vessel na merong coronary arteries. Because of increased blood supply, you also increase yung inflammatory cells at myocardial site, and then it will cause ventricular. Kaya if you do something, you give medications, you also have to monitor the patient because you have ventricular fibrillation. And this ventricular fibrillation is expected within 7 days after an MI. That's the reason why we admit the patient immediately after an MI. Okay? So for fibrillate, one is acute loss of blood supply. The other one is the injury current. Ito yung ini-explain ko sa inyo na yung ano siya, there will be inflammatory cells into the infarcted vessels and inflamed new myocardium, and this inflammation can result to infarction. Fibrillation. Yeah. So sympathetic activity, although is helpful, but can also aggravate fibrillation because too much of a sympathetic activity can result into fibrillation, especially if the myocardium is infarcted. Kaya hindi din maganda. And that is the reason why during MI, we give beta blockers within 24 hours. It has been shown, it has been proven to decrease mortality. So within 24 hours, we give beta blockers. That's part of our treatment. Of course, except if the blood pressure is low or if the heart rate is low. And the last is cardiac muscle weakness caused by the myocardial infarction. Alam na natin yon, myocardial related can be aneurysmal. And when these muscles are dilated or aneurysmal, hindi siya nakakadagdag sa stroke volume. In fact, it can aggravate a decrease in stroke volume or cardiac output, and eventually, if there is a decrease in cardiac output kasi, obstructed na nga yung coronary artery, decrease pa yung cardiac output, decrease pa yung perfusion, you are increasing the infarction. So, nagiging cycle lang siya. And this is one the reason why nagkakaroon din ng ventricular fibrillation. So, during the first day, or so after an acute infarct, there is little danger of rupture. Pero eventually, pag hindi mo ma-manage yung patient, lumalaki yung infarction, and these infarcted muscles are pliable, are soft, infarcted sila, and then it can rupture. Kaya nga, during the first 7 days, ayaw namin magbigay ng mga NSAIDs. Ayaw namin magbigay ng NSAIDs. Kasi it will, yung nagtatry kasing mag-heal yung myocardium nagtatry siyang mag-heal. So if you give NSAIDs, you will prevent that healing property. And so, magiging mahaba yung moment na soft yung myocardium, and you further aggravate myocardial rupture. But eventually, after that, after 2 weeks, medyo nag-heal na yung myocardium, kaya you can now give NSAIDs. So ito lang yung reason bakit hindi kami nagbibigay ng NSAIDs. So when a ventricle rupture, sinabi ko to kanina, blood will seep out into the pericardial space and it will cause cardiac tamponade. Alam niyo yung cardiac tamponade? If you don't know cardiac tamponade, the myocardium kasi needs to expand. It has to expand. So if there is volume of blood outside in the pericardial space, it cannot expand. Therefore, it decrease yung stroke volume, decrease yung cardiac output. Yan yung tinatawag na cardiac tamponade. And that's deadly. Okay? So, pag meron tayong myocardium, meron tayong tinatawag na ischemic penumbra. I don't know kung naririnig nyo yan. Meron kasing area niya ng patay na, infarcted na. Yung katabi naman yan is, ano lang siya parang di pa infarcted, ischemic pa lang, ischemia pa lang. So mabubuhay mo pa yon, and that's why you want to treat the patient, you want to give medication, you want to improve flow along the coronary artery disease para you decrease the infarcted size. Did you hear me? Hello?
Yes,
Okay. Okay. So, the degree of cardiac cellular death is determined by the degree of ischemia and the workload on the heart. So, ibig sabihin, pag decrease yung blood supply, that muscle will be infarcted. And then, if you increase the demand of that infarcted muscle, decrease na nga yung blood supply, you aggravate ischemia. And that is the reason why, pag meron kang coronary artery disease, we want to give vasodilators para ma-open up yung vessel, makapag-produce ka, mag-increase ka ng supply. And second, you also want to decrease the heart rate because a patient na may coronary artery disease, tas mabilis yung heartbeat, increase kasi yung myocardial oxygen demand in increased heart rate. And so you want to give beta blockers para yung heart rate niya medyo between 55 to 80 beats per minute lang para hindi increase yung myocardial oxygen demand. Ang problem, if the myocardium is already in hypertrophy, kasi pag hypertrophic yan, increase talaga yung demand yan. Then that's another factor for an infarction to be bigger. Kasi there is an increase in demand, tas decrease na nga yung supply, pangit yun. So these two-way, increased workload and decreased demand, kailangan mong i-target yan in a patient with an MI. Did you understand? Hello?
Yes, Doc.
Yes, Doc.
Okay. Coronary steal, this will come out in your exam. Kailangan nyo itong maintindihan. Ano yung coronary steal? Yung coronary steal, yun yung nangyayari. Bakit nagkakaroon ka ng subendocardial ischemia? Kasi ang nangyayari, paano ba? For example, nabara yung artery supplying the inferior wall of the left ventricle. Nabara siya. Nabara. So because of that bara, it has caused infarction of the inferior wall. And then because of an infarction, you release vasodilatory substance like adenosine. Pag yung mag-release ka naman ng adenosine, hindi naman yung vasodilatation doon lang sa infarcted area. Lahat naman ng myocardium will vasodilate. Naintindihan niyo ba yon? Hello?
Yep.
And then when you release sympathetic activity, hindi naman ang increased contractility, increased myocardial contractility, doon lang sa infarcted site, lahat naman ng muscle ng heart. So, ang other normal vessels. And then, kawawa si na merong obstruction because Hello? Narinig ba ako?
Hindi masyado daw.
Copy, Doc. Smile.
Medyo okay na? So yung coronary steal syndrome, the blood supply to the normal heart is improved because of vasodilation of this artery. So kawawa doon sa coronary artery obstruction kasi obstructed na nabawasan pa yung blood supply sa kanya, napunta pa doon sa normal cells. Did you understand that? Hello?
Yes, Doc.
Yes, Doc.
Coronary steal, it aggravates infarcted size, yung coronary steal. Kasi yung vasodilation, hindi naman specific lang doon sa may coronary artery disease. The vasodilatation is lahat naman eh. All the coronary arteries will vasodilate. So somehow these normal vessels will steal the blood supply that is supposed to go to the artery with coronary artery disease. Did you understand? Yan yung coronary steal syndrome. Okay. So even if you have an infarction, the heart naman has an ability to meron tayong tinatawag na reserve. It has a 300 to 400% reserve. So kahit nag-MI ka, nabubuhay naman. Hindi lahat ng nag-MI patient ko namamatay naman. Some of them survive. Most of them survive. And because of this coronary reserve. In fact, multiple MI buhay na buhay pa rin. And because we have a 300 to 400% of cardiac reserve. And these acidic substances like lactic acid, it's the one that stimulates the nerve ending and causes chest pain. Okay? And yun yung angina. And this is a protective mechanism. Kasi kung wala kang angina, you will not go to the hospital. You will not seek consultation. Kaya ang mga diabetic patients, because their nerves are affected, yung mga Schwann cells, whatever, are removed or affected, and then because of nerve problem, wala silang angina, kaya hindi sila nakakapagpa-check up. And another explanation to female, bakit yung pangit yung MI nila is because yung angina is decreased. The female patients do not feel pain most of the time. And this is the reason why hindi sila nakakapag-seek consultation. And so, they are just brought to the emergency room pag overt or grabe na malaki na yung infarction. Unlike male, according to studies, angina is more pronounced in male. Kaya yung lalaki, mas nakakaramdam daw ng pain more than female. And because of this angina, the male patients seek consultation. And because of early consultation, the infarcted size is somehow prevented. Nagiging mas lower yung infarction. And so, mas pangit ang female na nag-EMI compared sa male. Did you hear me?
Yes, Doc.
Doc.
Yes.
So, pag na broken hearted daw yung male, mas painful daw yun kaysa sa female. Daming arte. So the pain is usually beneath the upper sternum, or the refer the left arm. Ang angina can be from the jaw to the umbilicus. And that's because on embryology, yung origin ng heart, parang parehas naman from the jaw to the umbilicus. Kaya yung dermatome pattern, okay? So pain can be felt during exercise, or even emotions that increase metabolism of the heart. And that is because of the increased demand. And if there is an obstruction, there will be mismatch of supply and demand, and it will cause pain. It can last only for a few minutes, and it can also be exacerbated by cold temperature. Kaya maraming nag-EMI or nag-angina, or after eating. Pag nag-angina after eating, delikado yan actually. Kasi, di ba, if you eat, there's vasodilatation of the vessels in the gastrointestinal tract, and the blood supply will be directed there. Then, yun yung tinatawag parang still, parang ganun. So, if there's coronary artery, will be directed to the gastrointestinal tract and aggregate.
Doc, choppy.
Hello? Hello?
Wala si Doc.
Am I back? Or am
Yes
I out?
po.
Yes, Doc.
Yes, Doc.
Will have just seen during full stomach pag kumain sila, because there is dilatation of the arteries supplying the gastrointestinal tract. So the blood flow will be directed to the GI tract. Kaya it will cause ischemia. Or it will cause angina. Nagets niyo ba yon? Hello?
Apo, Doc.
Okay. So ito yung treatment to give nitroglycerin drugs, because nitroglycerin drugs dilate the coronary arteries and somehow improves blood supply. We also have to give beta blockers, and because these beta blockers will decrease sympathetic activity, alam na natin pag increasing sympathetic activity, it will increase heart rate, it will increase contractility, and therefore the workload is increased. So we want to give beta blockers because we don't want the demand to be increased. Okay. And another treatment is the coronary artery bypass graft. You don't need to know this at this point, but ito yung you create a new vessels that will surpass the obstructed artery. So the blood supply will be from this bypass. Ngayon, meron na tayong mga angioplasty, angiogram. So yung coronary extraction, balloon, and then we para maganda na yun. That's coronary angioplasty. Okay. Yay! Oh, Lord. Pasensya na. Questions? Baka mas makatulong yung questions. Ganun lang, masyadong bright yung window. Any question? Hello? Hello?